Welcome to the Deep Dive, where we don't just skim the surface. We plunge into the heart of complex topics, extracting those aha moments you truly crave. Today we're embarking on an unparalleled expedition, a true masterclass, into a region of the body that's both intimately familiar and yet endlessly complex, the human abdomen. For you, our discerning listener, our mission today is ambitious: to peel back every single layer, to unravel every intricate connection, and to truly master the anatomy and clinical relevance of the abdomen. We're talking about understanding this vital region like the elite professionals in the field, not just for recognition, but for true application. We've got a comprehensive stack of sources, and together we're going to unpack it all, leaving, well, no stone unturned.
Indeed. And the abdomen is, well, it's a marvel of biological engineering, a dynamic, roughly cylindrical chamber. It's home to an astonishing array of vital organs, all performing critical life-sustaining functions. But as you rightly point out, its true brilliance lies not just in its contents, but in the profound interconnectedness of its systems, from the subtle protection offered by its skeletal boundaries to the intricate dance of its nervous supply. We won't just explore what is there, we'll dissect why its precise arrangement, its developmental journey, and its vulnerabilities matter so profoundly in, well, pretty much every clinical scenario.
So if we're mapping an entire ecosystem, what's our itinerary? Think of it as a journey from the foundational blueprints to the everyday challenges of maintenance and repair. We'll begin by establishing its fundamental structure and boundaries, then rewind to witness how it develops, seeing how these origins create both strength and surprising vulnerabilities. From there, we'll trace its intricate network of blood vessels, nerves, and lymphatics, the body's internal highways and communication lines. And crucially, we'll then connect all this deep anatomical knowledge to real-world clinical understanding, informing everything from diagnosing common ailments to navigating complex surgical interventions. By the end, you'll possess a whole new, truly professional appreciation for the incredible world down there.
Exactly, a much deeper appreciation.
Okay, let's truly unpack this then. Our sources describe the abdomen as, well, a roughly cylindrical chamber. But before we dive into its fascinating contents, where exactly does this critical region begin and end? What are its defining boundaries?
That's the perfect starting point, because its boundaries immediately tell us something profound about its function and its interconnectedness. Superiorly, the abdomen is defined by the inferior margin of the thorax. Now, this isn't just an arbitrary line, it's specifically the inferior thoracic aperture, which is sealed by the diaphragm.
Ah, the diaphragm.
Exactly. Picture its bony margin. The lower border of vertebrae exterior, the entirety of rib 12, the discal end of ribacus, the arc of the costal margin, and the xiphoid process of the sternum. It forms this robust, almost dome-like superior boundary.
Okay.
Inferiorly, the deep abdominal wall seamlessly transitions into the pelvic wall right at the pelvic inlet, a distinct bony rim formed by the sacrum, pubic symphysis, and parts of the pelvic bones. Superficially, though, the inferior limit of the abdominal wall is simply the superior margin of the lower limb, marked quite dramatically by the inguinal ligament.
So it's not a simple isolated box. It really is continuous with both the chest and the pelvis. That seems like a crucial distinction right off the bat.
It's more than just a distinction. It's a fundamental principle of abdominal function and pathology. This continuity means the abdominal cavity is entirely open to the pelvic cavity.
Entirely open.
Yes. So if you have an infection or even just fluid, say, in one region, it can freely spread into the other. Think of it like a large shared internal space.
Right.
For example, the bladder, right?
Okay.
We typically think of it as a pelvic organ.
Right.
But when it's full, it can distend significantly up into the abdominal cavity. And of course, during pregnancy, the uterus expands dramatically from the pelvis way up into the abdomen.
Makes sense.
Furthermore, the abdomen isn't just connected top and bottom. It communicates directly with the thigh anteriorly through specific openings. This is where major vessels like the femoral artery and vein, the femoral nerve, lymphatics, and powerful muscles like the psoas major and iliacus pass through. It really highlights a dynamic, interconnected body region, not just a series of isolated compartments.
Fascinating.
And the internal chamber itself, the peritoneal cavity, it extends right down into the pelvis, providing this lubricated space where organs can slide freely. This unrestricted communication is vital, definitely, but it also presents unique clinical challenges.
Fascinating. So within this dynamic, interconnected chamber, what are the key residents? What's this bustling neighborhood comprised of?
It's an incredibly densely packed and vital neighborhood, you could say. The abdomen houses a remarkable array of structures, primarily the major elements of our gastrointestinal system. We're talking about the caudal end of the esophagus, which opens into the stomach,
Right.
followed by the small and large intestines, the duodenum, jejunum, ileum, cecum, ascending, transverse, descending, and sigmoid colon. Critically, it also contains the accessory digestive organs, the liver, the pancreas, and the gallbladder, all playing essential roles in digestion and metabolism.
The big players.
Absolutely. But beyond digestion, we also find the spleen, a crucial organ of the reticuloendothelial system, involved in blood filtration and immune function. The urinary system is prominently represented by the kidneys and ureters, processing waste and maintaining fluid balance.
Kidneys too, okay.
Yes, and high above the kidneys sit the suprarenal glands. You might know them as adrenal glands, endocrine powerhouses. And then, weaving through all of these organs is an incredibly dense and complex network of major neurovascular structures, arteries, veins, nerves, and lymphatics that serve every single one of these resident organs, ensuring their coordinated function. It's truly a microcosm of bodily systems.
It's clear the abdomen is a central hub. So when we talk about its main jobs, what are the core, multifaceted functions that make this region so indispensable to life? What does all this anatomy do for us?
Excellent question. The abdomen performs several critical, often underappreciated roles. Firstly, and perhaps most obviously, it houses and protects major viscera. Now, you might initially think of the abdominal wall as just muscle and soft tissue, but the protection is far more sophisticated.
How so?
Well, much of the liver, gallbladder, stomach, spleen, and significant parts of the colon are actually tucked high up under the domes of the diaphragm. These diaphragmatic domes project superiorly well above the palpable costal margin.
Oh.
Consequently, these particular abdominal viscera are directly protected by the lower ribs of the thoracic wall. Even the superior poles of the kidneys extend deep to the lower ribs. For the viscera not under this direct bony protection, the strong, multi-layered muscular walls of the abdomen itself provide essential support and a flexible yet firm protective shield against, external trauma and internal forces.
So it's not just a soft belly. It's like an internal armored vault, dynamically protected by both bone and muscle. That's interesting, and I've heard it's absolutely vital for breathing, too. How did that work?
Absolutely. The abdominal wall plays a surprisingly critical yet often overlooked role in breathing. During inspiration, when you inhale, the diaphragm contracts and descends, pushing the abdominal viscera downwards. For this to happen efficiently, the abdominal wall must relax to accommodate this inferior displacement and the resulting expansion of the thoracic cavity.
Okay, makes room.
Exactly. Then, during expiration, particularly forced expiration, the abdominal wall muscles contract. This action helps to elevate the domes of the diaphragm, pushing them back up, and significantly reduces the volume within the thoracic cavity.
Pushing the air out.
Precisely. This muscular contraction is essential for expelling air from the lungs, crucial for everyday forced breathing, but also for powerful actions like coughing or sneezing, where you need to rapidly expel material from the airway. It truly underscores the integrated nature of the respiratory and abdominal systems.
That dynamic interplay makes perfect sense. And speaking of pushing things out, our sources extensively detail the abdomen's ability to dramatically increase intra-abdominal pressure. What's the significance there?
Right. This ability to generate and control internal pressure is, well, it's a testament to the integrated strength of the abdominal wall and diaphragm, and it underpins several vital bodily functions. Contraction of the abdominal wall muscles, especially when combined with a fixed diaphragm, meaning air, is retained in the lungs by closing the laryngeal valves, like holding your breath, and can dramatically increase intra-abdominal pressure. This heightened pressure then acts like an internal piston, providing invaluable assistance. For example, it's critical for voiding the bladder during micturition, helping to expel urine.
Okay.
It's equally essential for expelling contents from the rectum during defecation, and most dramatically, it's a profoundly important force in childbirth, helping to push the baby through the birth canal. Without this finely tuned capacity for pressure generation, these basic yet vital bodily expulsive functions would be significantly compromised.
Wow. Okay, so if the abdomen is this dynamic, multifaceted chamber, it must rely on a remarkably robust structure. Let's delve into its architecture. What are the key bony elements that form its fundamental framework?
The abdominal wall is a sophisticated blend of both bone and muscle, carefully designed for protection and flexibility. The skeletal components provide a strong, unyielding framework, particularly posteriorly and superiorly. Posteriorly, we have the 5 lumbar vertebrae, L1 through L5, and their intervening shock-absorbing intervertebral discs. These form a powerful, flexible anchor for the posterior abdominal wall.
The lumbar spine, got it.
Yes. Superiorly, the bony parts of the inferior thoracic wall contribute significantly, including the costal margin, the full length of rib 12, the distal end of rib rime, and the xiphoid process of the sternum. These structures create a protective cage, particularly for the upper abdominal organs we discussed.
Right, covering things like the liver and spleen.
Exactly. Inferiorly, the superior expanded parts of the pelvic bones, specifically the broad wings of the ilia, contribute significantly to the lateral and inferior boundaries, and they articulate medially with the sacrum, forming a protective basin. These elements collectively provide both robust protection and critical attachment points for the powerful abdominal muscles.
So we have this foundational bony structure. The rest of the wall, then, is predominantly muscle, which our sources break down into different groups. Where should we begin our exploration of this muscular architecture?
Let's consider them by their position, moving systematically from posterior to anterior, understanding how each layer contributes to the wall's overall strength and flexibility. Posteriorly, lateral to the vertebral column, we find 3 crucial muscles: the quadratus lumborum, the psoas major, and the iliacus.
Psoas major. I've heard of that one. Hip flexor, right?
Major hip flexor, yes. It's a powerful, long muscle arising from the bodies and transverse processes of the T12 to L5 vertebrae and their intervertebral discs. It descends to attach to the lesser trochanter of the femur. Its primary action is, as you said, a major flexor of the thigh at the hip joint. The iliacus muscle fills the iliac fossa, and it joins the psoas major to form the iliopsoas, acting synergistically to flex the thigh. The quadratus lumborum, situated between rib 12 and the iliac crest, performs several functions. It depresses and stabilizes rib 12, helps to extend the lumbar spine, and assists in lateral bending of the trunk.
A stabilizer.
Precisely. And there's also the psoas minor, when present, which lies on the surface of the psoas major and provides a weak flexion of the lumbar column. These posterior muscles are more than just part of the wall. They're integral to both trunk and lower limb movement, deeply integrating these body regions.
That's a strong posterior foundation. What about the sides, the flanks, and how do they connect to the front?
Moving to the lateral parts of the abdominal wall, we find a truly ingenious design. 3 layers of flat muscles, oriented much like the intercostal muscles of the thorax, providing both immense strength and dynamic flexibility. From superficial to deep, these are the external oblique, the internal oblique, and the transversus abdominis.
3 layers. Okay.
Yes. The fibers of the external oblique run inframedially, sort of like putting your hands in your pockets. The internal oblique's fibers run superomedially, almost at right angles to the external oblique. And the transversus abdominis' fibers run mostly horizontally, like a wide muscular corset.
Like a corset. Interesting analogy.
It really functions that way. These muscles transition into broad, flat tendinous sheets, or aponeuroses, as they approach the midline. These aponeuroses then interlace and fuse to form the linea alba, a tough connective tissue band running vertically from the xiphoid process down to the pubic symphysis. This multi-layered, cross-fibered arrangement is a masterclass in providing robust support while allowing for the significant stretching and contraction required of the abdominal wall.
And then front and center, we have the well-known six-pack muscles, the rectus abdominis. What's their specific role and structure?
Yes, anteriorly we have the rectus abdominis, the pair of long, flat, segmented muscles that give the six-pack appearance when well developed. Each rectus abdominis spans vertically from the inferior thoracic wall specifically, the costal cartilages of ribs 5 through 7, and the xiphoid process down to the pelvis, attaching to the pubic crest, tubercle, and symphysis.
Segmented, you said. What does that mean?
What's particularly interesting about the rectus abdominis are the 3 or 4 tendinous bands or intersections that cross it horizontally, dividing it into segments. This segmentation isn't just for aesthetics. It provides structural integrity and allows for more localized contraction, adding strength.
Oh.
And often there's a small triangular muscle called the pyramidalis present as well, lying anterior to the rectus abdominis, attaching to the pubis and inserting into the linea alba. It's a minor muscle, sometimes absent, but it helps tense the linea alba. Now, collectively, these 5 anterolateral muscles, the external oblique, internal oblique, transversus abdominis, rectus abdominis, and pyramidalis, form a truly firm yet flexible wall. This wall isn't just a passive container, it's active. It's crucial for containing and protecting the abdominal viscera, maintaining posture against gravity, assisting in both quiet and forced breathing, and significantly, as we discussed, increasing intra-abdominal pressure for vital functions like childbirth, micturition, and defecation.
So much integration.
Each muscle has specific actions, but their integrated, coordinated function is what truly makes the abdominal wall so dynamic and absolutely vital.
It's amazing how their functions are so integrated, creating far more than just individual movements. This level of synergistic design is truly remarkable.
It genuinely is. And take the rectus abdominis and pyramidalis, for instance. They are enclosed within a structure called the rectus sheath. Now, this sheath is ingeniously formed by the aponeuroses, those flat tendons of the three flat muscles, the external oblique, internal oblique, and transversus abdominis.
Formed by the other muscles' tendons.
Exactly. And the construction of this sheath varies significantly along its length, and this variation has profound clinical implications. In the upper three-quarters of the rectus abdominis, the aponeurosis of the internal oblique muscle actually splits to contribute to both the anterior and posterior walls of the rectus sheath.
That's bliss, okay.
But in the lower one-quarter of the rectus, roughly below the midpoint between the umbilicus and the pubic symphysis, something changes. All three aponeuroses, external oblique, internal oblique, and transversus abdominis, pass entirely anteriorly to the rectus muscle.
All in front.
All in front. This leaves the rectus abdominis in direct contact with the transversalis fascia posteriorly. This change in the rectus sheath's composition is marked by a curved line known as the arcuate line. This anatomical detail isn't just academic. It critically dictates surgical approaches, especially below the arcuate line, and has implications for the stability of the abdominal wall and certain types of hernias. It's a detail elite professionals absolutely must master.
Wow, that's incredibly specific. Okay, beyond bone and muscle, our sources highlight several layers of fascia and the peritoneum. What's the role in this complex structure?
These layers are absolutely critical. They provide structural integrity, protect, compartmentalize, and crucially, allow for the necessary movement and sliding of tissues and organs. Starting from the outside, just beneath the skin, we first encounter the superficial fascia of the abdominal wall, which is essentially the subcutaneous tissue.
The fatty layer.
Yes, mostly. Above the umbilicus, it's typically a single relatively thin fatty layer, but below the umbilicus, it famously splits into two distinct layers, a detail of significant clinical importance. There's a superficial fatty layer, famously known as Camper's fascia, and a deeper, more membranous layer called Scarpa's fascia.
Camper's and Scarpa's.
Camper's fascia, the fatty layer, is continuous with the superficial fascia found in the thigh and the perineum. Scarpa's fascia, on the other hand, is much thinner and membranous, with very little to no fat. Inferiorly, it firmly fuses with the deep fascia of the thigh, what we call the fascia lata, just below the inguinal ligament.
Fuses there.
Yes, fuses tightly. Medially, it's strongly attached to the linea alba and the pubic symphysis. It also continues into the anterior perineum as superficial perineal fascia, or callus fascia, where it's firmly attached to the ischiocubic rami. In men, both Camper's and Scarpa's fascia blend over the penis to form the superficial fascia of the penis and then extend into the scrotum as a dartos fascia, giving the scrotum its wrinkled appearance.
And in women?
In women, the membranous layer extends into the labia majora and the anterior perineum. This extensive continuity is vital for understanding patterns of fluid accumulation or the spread of infection following trauma or surgery, like urine extravasation.
So these fascial layers aren't just local. They have far-reaching continuities across the body, dictating pathways for fluids and infections. That's important. What's next as we move even deeper?
Moving deeper, beneath the flat muscles, each is covered by its own investing fascia. But the most important of these for our discussion is the transversalis fascia. This is a robust, continuous layer that lines the entire abdominal cavity and extends down into the pelvic cavity, providing a strong internal lining.
Like wallpaper for the inside of the muscles.
That's a good way to think of it, yeah. It attaches posteriorly to the thoracolumbar fascia and blends seamlessly with the fascia covering the pelvic muscles, effectively becoming the parietal pelvic fascia. This continuity is profoundly important for understanding surgical planes and, critically, for identifying potential routes for hernias, as it forms the deepest covering for structures passing through the inguinal canal. It's like the inner skin of the abdominal wall musculature.
Okay, and deeper still?
Even deeper than the transversalis fascia lies the extraperitoneal fascia. This is a layer of connective tissue that contains varying amounts of fat, acting as a crucial separator. It separates the transversalis fascia from the innermost lining, the peritoneum. Structures that are embedded within this extraperitoneal layer are referred to as retroperitoneal, behind the peritoneum.
Retroperitoneal, okay. Like the kidneys.
Exactly. The kidneys and ureters are classic examples, as well as the abdominal, aorta, and IVC. Clinically, this layer is sometimes subdivided by surgeons into preperitoneal fascia anteriorly and retroperitoneal fascia posteriorly, particularly in surgical contexts like hernia repair, where the fat found in the inguinal canal is continuous with this preperitoneal fat. Understanding these fascial planes is absolutely essential for precise surgical dissection and repair.
And finally, we get to the peritoneum, which seems to be the ultimate lining, separating the abdominal wall from the visceral contents.
Exactly. The peritoneum is the innermost layer, a thin, glistening serous membrane composed of an epithelial-like single layer of cells called mesothelium, supported by a thin layer of connective tissue. It's remarkably similar to the pleura in the thorax or the pericardium around the heart.
A serous membrane, right?
Yes. It lines the walls of the abdominal cavity, where it's called parietal peritoneum, and then reflects onto the abdominal viscera, where it's called visceral peritoneum, providing either a complete or partial covering. The space between these two layers, the peritoneal cavity, is normally just a potential space.
Potential space, meaning it's not usually open.
Right. It's usually collapsed, containing only a small volume, maybe 50 milliliter or so, of lubricating peritoneal fluid. This fluid is absolutely crucial, allowing the abdominal organs to slide freely against each other and against the abdominal wall with minimal friction during digestion, breathing, and body movements.
So the organs are either fully within this space, surrounded by peritoneum, or partially covered with part of them behind the peritoneum.
Precisely. This distinction is fundamental to understanding abdominal anatomy and pathology. Abdominal viscera are broadly categorized based on their relationship with the peritoneum. They are either intraperitoneal, meaning they are almost completely suspended within the peritoneal cavity by folds of peritoneum called mesenteries.
Mesenteries, okay.
Or they are retroperitoneal, meaning they lie behind the parietal peritoneum and are only partially covered on one surface, usually the anterior one. Our sources highlight that major viscera, like the kidneys and ureters, as well as the abdominal, aorta, and IVC, are classic examples of primarily retroperitoneal structures.
And some organs change their status during development.
Exactly. Some organs, such as parts of the small and large intestines, like the duodenum, ascending and descending colon, initially develop intraperitoneally, but then, through a process of secondary fusion with the posterior abdominal wall during development, become secondarily retroperitoneal. This developmental journey explains their adult position and makes their relationships complex to trace without this understanding. These mesenteries are truly crucial structures. They are thin, double-layered sheets of peritoneum that not only suspend parts of the gut tube from the posterior and ancestrally the ventral abdominal wall, but also provide vital conduits. Through these mesenteries, the essential vessels, nerves, and lymphatics travel to reach the suspended viscera.
Those are like supply lines.
Very much so. Embryologically, a ventral mesentery was present for the proximal gut regions, and a dorsal mesentery extended along the entire length of the primitive gut tube. These embryonic mesenteries give rise to significant adult structures, such as the greater omentum and lesser omentum, which we'll definitely delve into shortly. They are indispensable for allowing organ mobility while ensuring their essential neurovascular connections are maintained.
This is where it gets really interesting, and a key anatomical difference often overlooked. The peritoneal cavity is a completely closed sac in men, but not in women. Why is that? What are the implications?
That's a critical anatomical and clinically significant distinction that has profound implications, especially for women's health. In men, the peritoneal sac is, as you said, completely closed. There are no direct openings from the outside world into the peritoneal cavity.
Sealed off.
Completely. In women, however, the peritoneal cavity is not entirely sealed. It has two small but direct openings at the fimbriated ends of the uterine tubes. These fimbriae, which are like finger-like projections, are open to the peritoneal cavity near the ovaries.
Ah, near the ovaries.
Yes, and they are continuous with the lumen of the uterine tubes, which then connects to the uterus and ultimately the vagina, opening to the outside environment. This means that, unlike in men, there's a potential pathway for communication between the peritoneal cavity and the external environment.
A direct pathway to the outside.
A direct pathway. While this anatomical route is vital for the passage of ova from the ovary into the uterine tube, it also means that infections ascending from the reproductive system, such as sexually transmitted infections or complications from childbirth, can potentially spread directly into the peritoneal cavity. This can lead to serious conditions like pelvic inflammatory disease or peritonitis in women, a risk that simply does not exist in men through this specific pathway. It's a striking example of sex-specific anatomical vulnerability.
Wow. Okay, to truly understand the intricate adult arrangement of the abdomen, we absolutely need to rewind the clock and embark on a journey through its development. Our sources emphasize a primitive gut tube as the starting point. What does this embryonic origin tell us?
Indeed, the blueprint for the adult abdomen is laid down remarkably early, beginning as a simple, longitudinally oriented tube, the primitive gut tube. Initially, it's suspended within the embryonic coalomic cavity by both dorsal and ventral mesenteries. This primitive gut tube is broadly divided into three main functional and developmentally distinct regions: the foregut, the midgut, and the hindgut.
Foregut, midgut, hindgut.
And the complex, often counterintuitive adult arrangement of organs, their mesenteries, and their specific neurovascular supply is a direct result of massive longitudinal growth of this tube, intricate and often dramatic rotations of selected parts, and the secondary fusion of some organs and their associated mesenteries to the body wall. Understanding these developmental events is not just fascinating, it's the master key to unlocking adult anatomy and anticipating its vulnerabilities. Let's quickly trace these divisions. The foregut gives rise to the distal esophagus, the stomach, and the superior part of the duodenum, specifically the segment superior to the major duodenal papilla where the bile duct enters. It also buds off the accessory digestive organs, the liver, gallbladder, and pancreas.
Got it.
The midgut is a much longer and more dynamic section. It forms the rest of the duodenum, inferior to the major duodenal papilla, the entire small intestine, jejunum, ileum, the cecum, the appendix, the ascending colon, and the proximal two-thirds of the transverse colon.
A lot comes from the midgut.
A huge amount. Finally, the hindgut develops into the distal one-third of the transverse colon, the descending colon, the sigmoid colon, and the superior part of the rectum. What's truly remarkable is that each of these embryonic sections maintains its primary arterial supply from the abdominal aorta in the adult. A fundamental, powerful clinical correlation for diagnosing vascular issues. Celiac trunk for foregut, SMA for midgut, IMA for hindgut.
It sounds less like a straightforward growth and more like an elaborate, choreographed dance of organs moving and fusing.
It is absolutely a complex ballet, and any misstep can have significant consequences later in life. Let's take foregut development as an example. The stomach undergoes a crucial 90-degree clockwise rotation around its longitudinal axis.
Clockwise rotation.
Yes. This rotation dramatically shifts its associated dorsal mesentery, which contains the developing spleen, over to the left side. As this rotation and shifting occur, parts of this dorsal mesentery become associated with and secondarily fuse to the left posterior body wall, fixing the spleen in its adult position. Simultaneously, the duodenum, along with its dorsal mesentery and a significant portion of the developing pancreas, swings to the right and also secondarily fuses to the posterior body wall. This process renders the duodenum and much of the pancreas secondarily retroperitoneal.
So they get stuck down.
Effectively, yes. They lose their mesentery and become fixed against the back wall, no longer freely suspended in the peritoneal cavity. This complex rotation and fusion also defines crucial spaces. The massive growth of the liver, originating in the ventral mesentery, combined with the secondary fusion of the duodenum, restricts the opening to a space formed by the ballooned dorsal mesentery of the stomach. This space, which lies posterior to the stomach and the liver, is known as the omental bursa, or lesser sac.
The lesser sac.
Yes, and its communication with the main peritoneal cavity, the greater sac, is restricted to a narrow opening called the omental foramen, sometimes called the epiploic foramen of Winslow. Surgeons need to be intimately familiar with this opening for various procedures, like accessing the pancreas.
And the greater omentum, often called the policeman of the abdomen, that's also a product of this developmental dance, isn't it?
Absolutely. The greater omentum is a particularly fascinating example of developmental ingenuity and a key player in abdominal defense. It's a derivative of the dorsal mesentery of the stomach. During development, it undergoes immense growth, enlarging inferiorly to form a massive apron-like structure that typically hangs down over and protects many other viscera in the abdominal cavity.
Like an apron.
Exactly. When a surgeon first opens the anterior abdomen, this is often the first structure they encounter. Its most remarkable feature, and the reason for its nickname, policeman of the abdomen, is its incredible ability to migrate.
You move.
It literally moves. In response to inflammation or infection within the abdomen, say from a ruptured appendix or a perforated ulcer, the greater omentum will migrate to that inflamed area and wrap itself around the compromised organ. It effectively walls off the inflammation, localizing the infection and preventing its widespread dissemination throughout the peritoneal cavity, which would be life-threatening. This self-sacrificing protective role is a testament to its developmental design.
Wow, that's incredible. A mobile protector.
It truly is. Now, midgut development involves an even more dramatic and clinically crucial series of events. During this phase, there's such rapid growth of the gastrointestinal system that the midgut loop temporarily herniates out of the abdominal cavity and into the umbilical cord.
Herniates out, like outside the body.
Into the umbilical cord, yes. This temporary physiological herniation is completely normal in the embryo. As the embryo grows and the connection with the yolk sac regresses, the midgut then returns to the abdominal cavity. While this return occurs, the two limbs of the midgut loop, the superior and inferior limbs, undergo a crucial 270-degree counterclockwise rotation around their combined central axis, which is the superior mesenteric artery.
270 degrees counterclockwise. That's a lot of turning.
It's a huge turn. And this complex rotation, combined with subsequent secondary fusions, positions organs like the ascending colon as secondarily retroperitoneal, while the cecum remains interperitoneal and the transverse colon remains suspended by its dorsal mesentery, the transverse mesocolon. Any malrotations during this stage can lead to severe clinical issues, such as midgut volvulus, where the bowel twists around the superior mesenteric artery, compromising blood flow and leading to a surgical emergency. Understanding this rotation is paramount for interpreting abdominal imaging and diagnosing neonatal emergencies.
Here's where it gets really interesting for me. Our sources highlight that the groin is an inherent weak area in the anterior abdominal wall. This seems counterintuitive for such a vital region. Why, developmentally speaking, is this the case?
That's precisely it. It's a fundamental vulnerability, and it's a direct, unavoidable consequence of the complex developmental journey and descent of the gonads, the testes and ovaries, in both sexes. Initially, the gonads form high up on the posterior abdominal wall near the kidneys.
Way up high.
Way up high. This seemingly distant origin sets the stage for a dramatic downward migration that necessarily creates structural pathways through the abdominal wall layers. A crucial structure guiding this descent is a cord of connective tissue called the gubernaculum. It connects the inferior pole of each developing gonad to the labioscrotal swellings, which are the primordial structures that will later differentiate into the scrotum in males and the labia majora in females.
Gubernacule, okay.
Simultaneously, a tubular, finger-like extension of the peritoneal cavity, known as the processus vaginalis, begins to project along this gubernaculum. As it pushes its way infero-anteriorly, it effectively drags and acquires coverings from each successive layer of the anterior abdominal wall it encounters.
So this processus vaginalis essentially paves the way, creating a preformed channel for the gonads to descend, like a tunnel being built.
Exactly, that's a great analogy. In men, this pathway becomes fully utilized. The testes, along with its intricate collection of associated vessels, ducts, the ductus deferens, and nerves, descends through this preformed channel into the scrotum. The processus vaginalis and its acquired coverings form the basic structure of the inguinal canal, which is essentially an oblique passage through the abdominal wall layers.
Oblique, not straight through.
Oblique, which adds some strength. The coverings acquired include, from the transversalis fascia, the deepest covering of the spermatic cord, the internal spermatic fascia, from the internal oblique musculature, the cremasteric fascia and muscle, and from the aponeurosis of the external oblique, the most superficial covering, the external spermatic fascia. Notably, the transversus abdominis muscle itself is not acquired as a covering because the processus vaginalis passes under its arching inferior fibers.
Interesting detail.
The completion of testicular descent also completes the formation of the spermatic cord, which is a comprehensive collection of structures passing between the testis in the scrotum and the abdomen. This critical bundle includes the ductus deferens and its artery, the testicular artery, the intricate pampiniform plexus of veins, important for temperature regulation, The cremasteric vessels and nerve, sympathetic and visceral afferent nerve fibers, lymphatics, and significantly remnants of the process vaginalis itself.
Quite a bundle.
Indeed, all these elements entered the deep inguinal ring, an opening in the transversalis fascia, traverse the inguinal canal, and exit through the superficial inguinal ring, an opening in the external oblique aponeurosis, enveloped by those acquired fascial layers. And the distal end of the processus vaginalis expands to enclose most of the testes, forming the tunica vaginalis, which helps the testes move freely within the scrotum.
And in women, since the ovaries don't descend all the way to the exterior, the inguinal canal's contents must be quite different, even though the same developmental process creates the canal.
That's precisely right. In women, the ovaries descend only to the pelvic cavity. They do not traverse the inguinal canal to the exterior. Therefore, while the inguinal canal is formed in a similar manner, its primary content in females is the round ligament of the uterus.
The round ligament.
Yes, it's a derivative and remnant of the gubernaculum. This cord-like structure passes from the uterus, through the inguinal canal, and attaches into the connective tissue of the labia majora. As it traverses the inguinal canal, it acquires the same three coverings derived from the abdominal wall layers as the spermatic cord in men. So while the specific contents passing through the canal differ significantly between sexes, the fundamental developmental process of creating this oblique passage through the abdominal wall, and thus a potential area of weakness, remains the same.
So the weakness is there for both sexes.
Exactly. Crucially, in both sexes, the final and critical step in this developmental sequence is the complete obliteration or closure of the processus vaginalis after descent is complete. If this process does not occur fully, leaving a patent open connection between the peritoneal cavity and the inguinal canal, or if the abdominal wall layers are inherently weakened by other factors like aging, injury, or chronically increased intra-abdominal pressure.
Like from coughing or heavy lifting.
Precisely. Then a persistent weakness remains in the inguinal region. This inherent developmental vulnerability makes the inguinal area the single most common site for inguinal hernias, where a peritoneal sac, potentially containing abdominal contents like bowel, can protrude through the abdominal wall. This is a powerful illustration of how our developmental origins directly shape our adult anatomical vulnerabilities, a detail truly mastered by elite professionals in surgery and anatomy.
Fascinating. Okay, having mapped the structure and traced its remarkable development, let's now dive into the body's internal plumbing and wiring. The abdominal aorta is clearly the central primary pipeline for arterial supply, isn't it?
It is indeed the grand arterial highway. The abdominal aorta originates at the aortic hiatus of the diaphragm, anterior to the lower border of vertebra T12. From there, it descends through the abdomen, positioned anterior to the lumbar vertebrae, giving off vital branches along its course.
How far down does it go?
By the time it reaches vertebra L4, typically it performs its crucial bifurcation, splitting into the two common iliac arteries, which then supply the pelvis and lower limbs. This extensive vessel provides essential arterial supply to all abdominal viscera, the abdominal wall itself, and the structures of the retroperitoneum, with its branches often serving as a powerful anatomical reminder of the embryonic development of the gut we just discussed.
Right, you mentioned that connection.
Yes, understanding its branching pattern is fundamental for diagnosing and treating a vast range of conditions, especially vascular ones. The abdominal aorta has three distinct sets of branches: anterior, lateral, and posterior. For the gastrointestinal system, the three unpaired anterior branches are absolutely critical, and they correlate precisely with the foregut, midgut, and hindgut divisions.
Foregut, midgut, hindgut again. Let's hear them.
First, the celiac trunk, often simply called the celiac artery. This vital vessel supplies the entire foregut derivatives. It arises as a very short, wide trunk right at the upper border of L1, just below the diaphragm. Its extensive distribution includes the abdominal esophagus, the entire stomach, the superior part of the duodenum, up to the major duodenal papilla, the liver, the pancreas, the gallbladder, and the spleen, which, remember, develops within the foregut's dorsal mesentery.
So one short trunk supplies all of that.
Yes, but it branches almost immediately into three major arteries. The left gastric artery, supplying the lesser curvature of the stomach and the abdominal esophagus. The splenic artery, a famously tortuous vessel supplying the spleen, much of the pancreas, and the left part of the greater curvature of the stomach via short gastric and left gastroomental arteries. And the common hepatic artery, supplying the liver, gallbladder, and duodenum via its branches like the hepatic artery proper and gastroduodenal artery. Each of these is a major player.
Okay, celiac trunk for the foregut. Next.
Second, The superior mesenteric artery, SMA, the lifeline for the midgut. It originates at the lower border of L1, just inferior to the celiac trunk. This artery supplies everything from just inferior to the major duodenal papilla in the duodenum, through the entire jejunum and ileum, the cecum, the appendix, the ascending colon, and the proximal two-thirds of the transverse colon.
That's a huge territory.
It is. Its significant branches include numerous jejunal and ileal arteries, which form characteristic arcades and vasa recta in the mesentery supplying the small bowel, the ileocolic artery supplying the terminal ileum, cecum, and appendix, the right colic artery supplying the ascending colon, and the middle colic artery supplying the transverse colon. This extensive network ensures robust perfusion for the vast majority of our small and much of our large intestine.
And the third interior branch.
Third, and finally, the inferior mesenteric artery, IMA, which supplies the hindgut. This is the smallest of the three anterior branches and arises anterior to the body of L3, about 3 to 4 centimeters above the aortic bifurcation. It supplies the distal one-third of the transverse colon, the descending colon, the sigmoid colon, and the superior part of the rectum. Its branches are the left colic artery, supplying the descending colon and the distal transverse colon, several sigmoid arteries, supplying the sigmoid colon, and the superior rectal artery, which is its terminal branch, supplying most of the rectum. While smaller, its role is equally critical for the final stages of digestion and defecation.
So a remarkably clear, developmentally based segmental supply for the gut. That's quite elegant. But in such a vital system, are there any vulnerable overlap zones or watershed areas, as they're sometimes called, where blood supply might be compromised?
An absolutely crucial question for any professional, and yes, there are. While there's a potential watershed area in the descending part of the duodenum between the celiac trunk and superior mesenteric artery supply, it's relatively rare for this specific region to become ischemic in isolation due to, well, pretty rich collateralization there.
Okay.
However, the watershed area between the superior mesenteric artery and the inferior mesenteric artery, specifically at the splenic flexure of the colon, is of much greater clinical significance and far more vulnerable to ischemia.
The splenic flexure. Why there?
This region, often receiving marginal blood flow from the most distal branches of both the middle colic artery from the SMA and the left colic artery from the IMA, makes it particularly susceptible to damage if systemic blood pressure drops significantly, hernia and shock, or in cases of severe atherosclerotic vascular disease blocking flow. It's a key area to monitor for ischemic colitis, where the bowel tissue starts to die from lack of oxygen.
That's a critical point.
Absolutely. And clinically, narrowing of the celiac trunk and/or the superior mesenteric artery, typically due to atherosclerosis, can lead to a debilitating condition known as mesenteric angina. This presents a severe, crampy abdominal pain that characteristically occurs shortly after eating.
Pain after eating.
Yes. The reason is simple. Digestion demands a significant increase in blood flow to the gut, but the stenosed or narrowed vessels cannot meet this demand. The resulting ischemia causes intense pain. Patients often develop a profound fear of food due to this pain, leading to rapid and significant weight loss. Diagnosis often requires specialized imaging like CT angiography or conventional aortic angiography, where the stenoses are best appreciated in a lateral view. Understanding these vascular vulnerabilities is a hallmark of elite practice.
Okay, what goes in must eventually come out. So how does venous blood return from these incredibly active organs? I know the abdominal GI system has a unique drainage pathway, doesn't it?
It does, and this pathway is fundamentally different from systemic venous drainage elsewhere in the body, which is why it's so vital to master. All venous drainage from the abdominal gastrointestinal system, including the spleen and pancreas, is unique in that it passes through a second vascular bed, the hepatic sinusoids within the liver, before ultimately returning to the heart. This is the hepatic portal system.
Portal system.
The main pipeline here is the portal vein, a large valveless vein that forms posterior to the neck of the pancreas, typically at the level of vertebra L2, from the union of two major veins, the splenic vein and the superior mesenteric vein.
So those two join to make the portal vein.
Correct. Let's trace its key tributaries. The splenic vein drains the spleen itself, receives blood from the pancreas, and also collects blood from the left part of the greater curvature of the stomach via the left gastroomental vein, as well as several short gastric veins. The superior mesenteric vein, SMV, drains the extensive midgut region, the small intestine, jejunum and ileum, the cecum, ascending colon, and the transverse colon.
Mirroring the artery.
Precisely. And the inferior mesenteric vein, IMV, which drains the hindgut, the rectum, sigmoid colon, descending colon, and the splenic flexure, usually joins the splenic vein, though sometimes it might join the superior mesenteric vein or the portal vein directly. So all the nutrient-rich, deoxygenated blood laden with absorbed products of digestion is meticulously funneled into the liver first.
First stop, the liver.
Always. The liver then processes these nutrients, detoxifies substances, metabolizes drugs, and only then does the blood return to the systemic circulation via the hepatic veins, which drain into the inferior vena cava.
So that nutrient-rich blood from everything we eat goes directly to the liver for processing. This sounds like an incredibly efficient system. But what happens if there's a problem with the liver itself, like in conditions such as cirrhosis? What are the consequences of that backup?
This is where the profound clinical significance of the portal system truly emerges, demonstrating both the body's compensatory mechanisms and its critical vulnerabilities. In conditions like hepatic cirrhosis, the liver's normal, delicate architecture is severely and irreversibly distorted by widespread fibrosis, scar tissue basically, and the formation of regenerative nodules.
Scarring up the liver.
Exactly. This distortion obstructs blood flow through the liver, leading to a significant increase in pressure within the portal vein and its draining tributaries, a dangerous condition known as portal hypertension. When the liver can no longer adequately accommodate or process the portal blood flow, the pressure forces blood to seek alternative, collateral routes to return to the heart, bypassing the liver. These alternative pathways are through what we call portosystemic anastomoses.
Portosystemic anastomoses, backup routes.
Backup routes, exactly. These are natural connections that exist between the portal venous system and the systemic venous system, which drains directly back to the heart. But they are normally tiny and clinically insignificant. However, with portal hypertension, they can become greatly enlarged, tortuous, swollen, and incredibly fragile, leading to three major, potentially life-threatening clinical manifestations. Firstly, at the gastroesophageal junction, where tributaries of the left gastric vein, part of the portal system, anastomose with esophageal veins draining into the azygosystem, part of the systemic circulation. If these enlarge, they form swollen, superficial vessels known as esophageal varices.
Varices, like varicose veins, but in the esophagus.
Precisely. And they are highly susceptible to rupture due to their thin walls and the high pressure. Rupture can cause torrential, life-threatening upper gastrointestinal hemorrhage. Very dangerous. Secondly, around the anus, where the superior rectal vein, draining into the inferior mesenteric vein and thus the portal system, anastomoses with the middle and inferior rectal veins, which drain directly into the internal iliac veins and thus the systemic system. Enlargement here leads to anorectal varices, more commonly known as hemorrhoids, which can be painful and bleed, though usually not as catastrophically as esophageal varices. Thirdly, around the umbilicus. Here, paraumbilical veins, remnants from fetal circulation connected to the portal system via the ligamentum teres, anastomose with superficial veins of the anterior abdominal wall, systemic veins. When these collateral veins enlarge and become visibly prominent, radiating outwards from the umbilicus like spokes on a wheel or like snakes.
You can see them on the skin.
Yes, you can see them. It creates a striking and diagnostic pattern known as caput medusae, named after the snake-haired Medusa from Greek mythology. These enlarged shunts are the body's desperate attempt to bypass the obstructed liver, but they carry immense clinical risks and are a clear hallmark of advanced liver disease and severe portal hypertension.
Those sound like extremely serious and vivid complications.
Yeah.
The powerful demonstration of how interconnected these systems are. What about the main systemic vein in the abdomen, the inferior vena cava?
The inferior vena cava, IVC, is indeed the major systemic vein in the abdomen, and it's a critical conduit. It lies just to the right of the vertebral column, ascending anterior to the psoas major muscle, and finally penetrates the central tendon of the diaphragm at approximately vertebral level T8, directly draining into the right atrium of the heart.
So it collects blood from everywhere except the gut.
Essentially, yes. It's responsible for collecting deoxygenated blood from the entire abdomen, except the portal drainage initially. Pelvis, perineum, and lower limbs. It receives several significant tributaries, including the hepatic veins after the liver has processed portal blood, the renal veins, the gonadal veins, testicular or ovarian, lumbar veins, and the common iliac veins where they join. The left renal vein is particularly notable anatomically. It crosses the midline, anterior to the aorta, but often posterior to the superior mesenteric artery where it originates. This position makes it susceptible to compression by an aneurysm in either of these vessels, or sometimes just by the angle of the SMA, a condition known as nutcracker syndrome, which can cause flank pain and hematuria.
Nutcracker syndrome, okay.
Clinically, a chronic thrombosis of the inferior vena cava, a blood clot obstructing the IVC, can lead to severe lower limb edema and, crucially, to the development of prominent collateral veins on the anterior abdominal wall, often coursing cranially upwards. This is the body's attempt to bypass the obstruction, routing blood through superficial systemic veins like the thoracoepigastric vein to reach the superior vena cava, as we see, providing a critical diagnostic clue on physical examination.
So we've traced the blood supply, both arterial and venous. What's the lymphatic story in the abdomen? Where does all that interstitial fluid and immune surveillance material eventually go?
The lymphatic drainage from deep abdominal structures generally mirrors the pattern of major blood vessels, much like the venous system, but with a distinct ultimate destination and critical clinical significance, especially in cancer staging. Lymph from these viscera doesn't just randomly collect. It converges on highly organized collections of lymph nodes.
Organized groups of nodes.
Yes. These include large groups of pre-aortic lymph nodes, the celiac, superior mesenteric, and inferior mesenteric groups, located right at the origins of the corresponding arterial branches. There are also lateral aortic or lumbar nodes positioned along either side of the aorta.
Following the arteries again.
Exactly. Specifically, lymph from the foregut meaning organs supplied by the celiac trunk drains to the celiac nodes. Lymph from the midgut organs supplied by the superior mesenteric artery drains to the superior mesenteric nodes, which then, in turn, drain further up into the celiac nodes. And lymph from the hindgut organs supplied by the inferior mesenteric artery drains to the inferior mesenteric nodes, which subsequently drain into the superior mesenteric nodes and then often upwards again.
So it's a staged drainage system.
It is. Ultimately, lymph from all these preaortic nodes coalesces and enters the cisterna chyli, which is this dilated sac-like origin of the thoracic duct, usually found around L1, L2 between the aorta and the right crus of the diaphragm. The thoracic duct then ascends through the thorax, eventually returning processed lymph and chyle, fat-laden lymph from the intestines, to the systemic circulation in the neck, typically at the junction of the left subclavian and internal jugular veins.
Cisterna chyli, the start of the thoracic duct.
Got it. And additionally, those lateral aortic or lumbar nodes, also known as periaortic nodes, are critically important. These nodes receive lymphatic drainage directly from organs like the kidneys, the suprarenal glands, and notably from the gonads, the testes in men and the ovaries in women.
From the gonads, even after they descend.
Yes. This predictable pattern of lymphatic drainage is absolutely crucial for understanding the spread of diseases, particularly cancers. For instance, testicular cancer characteristically spreads first to these para-aortic lymph nodes high up in the abdomen, because the testes originally develop high in the abdomen near the kidneys and retain their embryonic lymphatic drainage pathways even after descent into the scrotum.
That's counterintuitive, but makes developmental sense.
Exactly. Similarly, ovarian cancers can spread to these nodes. Enlarged retroperitoneal lymph nodes are a key feature in the diagnosis and staging of lymphomas and metastatic spread from various abdominal and pelvic cancers. This knowledge guides surgical interventions like lymph node dissections and oncological treatments like radiation therapy.
The abdomen is clearly a highly coordinated system, a true symphony of organs. How is all this intricate activity wired up and regulated? What's the nervous system doing here?
You're right. It's an incredibly complex and exquisitely coordinated system. Abdominal viscera receive both extrinsic and intrinsic innervation. Extrinsic innervation involves motor impulses originating from and sensory information returning to the central nervous system. It's the master control from the brain and spinal cord. Intrinsic innervation, on the other hand, is handled by the enteric nervous system, a remarkable, largely self-sufficient network embedded within the walls of the gastrointestinal tract itself, often called the gut's brain.
Okay, let's break down that extrinsic innervation first, focusing on the autonomic nervous system with its sympathetic and parasympathetic branches. What do they control?
Absolutely. The extrinsic visceral efferent fibers are part of the autonomic nervous system, which operates largely below conscious control, orchestrating our internal environment. The sympathetic components generally prepare the body for fight or flight, typically inhibiting GI motility and secretion, constricting blood vessels, except to skeletal muscle, and causing contraction of sphincters.
Fight or flight in the gut.
Sort of. Preganglionic sympathetic fibers destined for the abdomen originate from spinal cord levels T5 down to L2. They travel via specialized nerves called splanchnic nerves, specifically the greater T5, T9, T10, lesser T10, T11, and least T12 thoracic splanchnic nerves, as well as lumbar splanchnic nerves, L1, L2. These nerves bypass the sympathetic trunk ganglia, where somatic nerves synapse, and instead travel to prevertebral ganglia.
Prevertebral ganglia.
Yes, these are crucial ganglia located anterior to the abdominal aorta, often clustered around the origins of the major gut arteries. They include the celiac, superior mesenteric, inferior mesenteric, and aortocarinal ganglia. It's here that the preganglionic fibers synapse. From these prevertebral ganglia, postganglionic fibers then follow the arteries, traveling within the periarterial plexuses to innervate their target viscera, providing widespread sympathetic control.
And the parasympathetic side, which we often associate with rest and digest, how does that system interface with the abdomen?
Exactly. The parasympathetic components promote rest and digest functions, generally increasing GI motility, peristalsis, promoting secretion of digestive juices, and relaxing sphincters. They come from two distinct sources, beautifully mirroring the developmental divisions of the gut again.
Vagus nerve.
Primarily, yes. For the foregut and midgut, all the way down to the splenic flexure of the colon, the parasympathetic innervation is supplied by the vagus nerves X. These nerves enter the abdomen as anterior and posterior vagal trunks, traveling with the esophagus through the diaphragm. They branch extensively, contributing preganglionic fibers to the prevertebral plexus and sending branches directly to the walls of the target organs. There, they synapse with intrinsic ganglion cells within the organ walls, part of the enteric system.
So for the hindgut.
For the hindgut, specifically, the distal one-third of the transverse colon down to the superior rectum, the parasympathetic supply comes from a different source, the pelvic splanchnic nerves. These arise from spinal cord levels S2, S4. They are unique because they carry preganglionic parasympathetic fibers directly from the spinal nerves, ascending out of the pelvis through the hypogastric plexuses to innervate the hindgut, synapsing within the walls of the colon and rectum.
Okay, S2, S4 for the hindgut.
Precisely. And importantly, visceral sensory fibers carrying information about things like stretch, distension, inflammation, or ischemia generally parallel these autonomic motor pathways back to the central nervous system. This is precisely why visceral pain, which is often poorly localized, crampy, and vague, can be referred to distant somatic areas corresponding to the same spinal cord levels of origin.
Referred pain again.
Yes. For example, pain from appendicitis, midgut, might initially start around the umbilicus T10 dermatome before localizing. Pain from the gallbladder, foregut, might refer to the right shoulder via phrenic nerve irritation sharing C3-C5 roots. This concept of referred pain is absolutely critical for clinical diagnosis.
It's astounding that the gut has its own brain, the enteric nervous system, allowing it a degree of autonomy. Can you elaborate on that? That sounds fascinating.
That's a very apt analogy, and it speaks to the incredible sophistication of the digestive system. The enteric nervous system, ENS, is often called the second brain or the gut's brain because it consists of a largely self-sufficient, incredibly complex network of motor neurons, sensory neurons, and interneurons. It actually contains more neurons than the entire spinal cord.
More than the spinal cord. Wow.
Yes. These neurons are organized into two major interconnected plexuses within the GI tract walls. The myenteric Auerbach's plexus, located between the longitudinal and circular muscle layers, primarily controlling motility and peristalsis, and the submucosal Meissner's plexus, found in the submucosa, primarily regulating secretion, absorption, and local blood flow.
Myenteric for muscle, submucosal for secretions.
Broadly speaking, yes. This intrinsic system independently regulates and coordinates complex gut activities like peristalsis, the coordinated wave-like contractions that propel food along segmentation contractions for mixing, gastric and intestinal secretion, and local blood flow adjustments based on digestive activity. While it can function autonomously, its activity is constantly modified and modulated by the extrinsic sympathetic and parasympathetic input we just discussed. This allows for overall central nervous system oversight and response to broader bodily needs, like diverting blood flow during exercise, while maintaining crucial local fine-tuning for efficient digestion and absorption without requiring constant conscious intervention. It's a beautiful example of hierarchical control.
Beyond the viscera and their intricate wiring, what about the abdominal wall itself and the connections to the lower limbs? That's where the lumbar plexus comes in, right? Providing somatic innervation for movement and sensation.
Precisely. While the autonomic nervous system handles the viscera, the somatic innervation, meaning voluntary muscle control and conscious sensation, to the abdominal wall, parts of the perineum, and much of the lower limb is primarily managed by the lumbar plexus.
Lumbar plexus, where is it formed?
This is a critical network of nerves formed from the anterior rami or ventral rami of spinal nerves L1, L2, L3, and part of L4. It's uniquely located within the posterior abdominal wall, actually embedded within the substance of the psoas major muscle or lying deep to it. Its various branches emerge from the psoas at different points and provide both motor movement and sensory sensation innervation, integrating the abdominal core with the lower body.
Okay, so what are some key branches we should know?
Let's highlight some key branches and their clinical significance, as injury to these can cause specific deficits. The iliohypogastric and ilioinguinal nerves, both originating primarily from L1. The iliohypogastric supplies parts of the internal oblique and transversus abdominis muscles and provides cutaneous sensation to the skin over the posterolateral gluteal region and the hypogastric pubic region. The ilioinguinal also innervates abdominal wall muscles and supplies cutaneous sensation to the upper medial thigh, the root of the penis and anterior scrotum in men, or the mons pubis and labia majora in women. It uniquely emerges through the superficial inguinal ring alongside the spermatic cord or round ligament, making it particularly susceptible to injury or entrapment during inguinal hernia repair, which can lead to chronic groin pain.
Hernia surgery risk.
Definitely. Then there's the genitofemoral nerve, arising from L1 and L2. It characteristically pierces through the psoas major muscle. Its genital branch supplies the male cremasteric muscle responsible for the cremasteric reflex. Lightly stroking the inner thigh causes retraction of the testes on that side, and provides sensory innervation to the anterior scrotum, or labia majora. The femoral branch supplies a small patch of skin on the upper anterior thigh. Testing the cremasteric reflex helps assess the integrity of the L1, L2 spinal cord segments.
Mhm.
The lateral cutaneous nerve of the thigh, also called lateral femoral cutaneous nerve, from L2 and L3, emerges from the lateral border of the psoas major, crosses the iliacus, and passes under or through the inguinal ligament near the acis to supply skin on the anterior and lateral thigh down towards the knee. Compression of this nerve, often where it passes near the inguinal ligament, for example due to tight clothing, obesity, or pregnancy, causes a condition called neuralgia paresthetica, characterized by tingling, numbness, or burning pain in its distribution.
Neuralgia paresthetica, interesting.
The obturator nerve, formed from L2, L3, and L4, descends medially, emerging from the medial border of the psoas major, and enters the medial adductor compartment of the thigh by passing through the obturator foramen in the pelvis. It primarily supplies the adductor muscles of the medial thigh and provides some skin sensation on the medial thigh. Injury can weaken thigh adduction. And finally, the largest branch, the femoral nerve, also from L2, L3, and L4. It emerges from the lateral border of the psoas major, lower down than the lateral cutaneous nerve. It's a major nerve, supplying the iliacus and pectineus muscles in the pelvis, and then entering the anterior thigh to supply the powerful quadriceps femoris muscle group, essential for knee extension, and the sartorius muscle. It also provides skin sensation on the anterior thigh and the medial aspect of the leg down to the foot via its saphenous branch. Injury here causes significant difficulty with walking and knee extension.
Wow, that plexus covers a lot of ground.
It really does. This comprehensive plexus underscores the complex, interconnected nature of abdominal and lower limb innervation, and why a deep understanding of it is absolutely vital for diagnosing pain, weakness, or sensory loss in these regions, whether from nerve root compression in the spine, plexus injury within the psoas, or peripheral nerve entrapment.
Okay, with such an intricate internal landscape, understanding precisely where everything is located is absolutely crucial, especially in the clinical setting. Our sources describe different mapping systems for the abdomen. How do we orient ourselves for examination and description?
That's a foundational skill for any clinician, absolutely. It allows for precise communication between colleagues and accurate diagnosis. For describing organ location, palpating masses, or localizing pain, two main topographical patterns are universally used. The first is the simpler four-quadrant pattern.
Upper right, upper left.
Exactly. This divides the abdomen by a horizontal transumbilical plane, a line passing horizontally through the umbilicus and the intervertebral disc between L3 and L4, intersecting with a vertical median plane running down the midline. This creates the familiar right upper quadrant, RUQ, left upper quadrant, LUQ, right lower quadrant, RLQ, and left lower quadrant, LLQ. It's quick, easy, and often sufficient for initial localization of pain or findings.
Simple enough. What's the more detailed one?
The second, more detailed system is the 9-region pattern. This uses 2 vertical lines, typically the midclavicular planes, lines dropped vertically from the midpoint of each clavicle, and 2 horizontal planes. The upper horizontal plane is the subcostal plane, passing just inferior to the costal margin, usually at the lower border of L3. The lower horizontal plane is the intertubercular plane, connecting the tubercles of the iliac crests, usually at the upper border of L5.
9 boxes, basically.
9 boxes, yes. These divide the abdomen into 3 central regions. Superiorly, the epigastric region, centrally the umbilical region, and inferiorly the hypogastric or pubic region, and then 3 regions on each side. Superiorly, the right and left hypochondrium under the ribs, laterally, the right and left flank or lateral lumbar regions, and inferiorly, the right and left groin or inguinal regions. This more granular map allows for much finer localization of symptoms and findings, which is essential for developing a precise differential diagnosis.
And these regions connect directly to the concept of referred pain you mentioned earlier, don't they? That's a vital clinical correlation that can be a real diagnostic puzzle if you don't understand it.
Absolutely. It's a cornerstone of clinical abdominal assessment. Understanding referred pain is critical because pain from abdominal viscera, due to their shared sensory pathways entering the spinal cord, is often perceived not over the organ itself, but in cutaneous areas, dermatomes, supplied by somatic sensory nerves from the same spinal cord levels.
So the brain gets confused about the source.
That's a good way to put it. The brain interprets the signal as coming from the more commonly stimulated somatic pathway. This anatomical understanding allows for remarkably precise diagnostic reasoning. Pain originating from the foregut, that's organs supplied by the celiac trunk, like the stomach, liver, gallbladder, pancreas, spleen, proximal duodenum, is typically referred to the epigastric region, roughly T7, T9 dermatomes. Think of the central burning pain of a stomach ulcer or pancreatitis. Pain from the midgut organs supplied by the superior mesenteric artery, such as the distal duodenum, small intestine, appendix, ascending colon, proximal transverse colon, is usually referred to the umbilical region, roughly T10 dermatome. This is classic for the initial vague central pain of early appendicitis. And pain from hindgut organs supplied by the inferior mesenteric artery, like the distal transverse colon, descending colon, sigmoid colon, rectum, is commonly referred to the pubic or hypogastric region, roughly T11L1 dermatomes. This can be indicative of issues like sigmoid diverticulitis or rectal pain. This knowledge helps clinicians narrow down the source of discomfort, even when the patient points to a seemingly unrelated area, transforming a vague symptom into a targeted diagnostic pathway.
With so much complexity inside, what can we actually feel or see on the surface to guide us in locating these deeper structures? What are the palpable landmarks we use for physical examination?
Excellent question. The ability to mentally map deep structures using surface landmarks is a hallmark of an elite professional examiner. Numerous palpable landmarks help us delineate the extent of the abdomen and project deep structures, which is fundamental for physical examination. Superiorly, the costal margin is readily palpable, forming that distinct arch separating the abdominal wall from the thoracic wall.
Okay, the bottom of the ribs.
Exactly. Inferiorly, key landmarks include the pubic tubercle, a small but distinct bony prominence on the superior ramus of the pubis, important for hernia diagnosis, the anterior superior iliac spine, ASIS, the easily felt point of the hip bone anteriorly, and the curved ridge of the iliac crest itself, which you can follow posteriorly.
ASIS and iliac crest. Got it.
A line drawn between the ASIS laterally and the pubic tubercle medially marks the position of the inguinal ligament, which is actually the thickened lower border of the external oblique aponeurosis. This ligament is a crucial dividing line between the anterior abdominal wall and the thigh, and a key reference for inguinal and femoral hernias. The iliac crest separates the posterolateral abdominal wall, the flank, from the gluteal region.
Okay, so by understanding these surface points, you can indeed visualize the deeper structures, including major blood vessels and organs, right? How does that work?
Yes, absolutely. For instance, the transpyloric plane. This isn't usually palpable itself, but it's located about midway between the jugular notch of the sternum superiorly and the pubic symphysis inferiorly. Clinically, it often corresponds to the tip of the 9th costal cartilage laterally. This plane correlates beautifully with the lower aspect of the L1 vertebra.
L1. Why is that level so important?
It's an incredibly crucial reference point for clinicians because it helps locate several vital structures. The pyloric orifice of the stomach, where it joins the duodenum, the hillock of the kidneys, where the renal arteries, veins, and ureters enter-exit, the neck of the pancreas, the origin of the superior mesenteric artery from the aorta, and the formation of the portal vein. So knowing that L1 landmark is huge.
Wow, a lot happens at L1.
A lot happens there. We can also approximate other vertebral levels using surface landmarks. For example, the highest point on the iliac crest, when palpated from the side, generally corresponds to the level of the L4 vertebra, or the L4-L5 intervertebral disc. This is typically where the abdominal aorta bifurcates into the common iliac arteries, a vital landmark for assessing aneurysms or planning vascular surgery. These topographical and palpable correlations are indispensable for understanding imaging findings like CT or MRI, planning surgical approaches, and interpreting clinical signs accurately.
Can we project specific organs onto these quadrants or regions?
We certainly can, at least their general locations. The liver and gallbladder are primarily situated in the right upper quadrant, RUQ, and the right hypochondrium epigastric regions. The liver's inferior margin can often be palpated descending below the right costal margin, especially during deep inspiration in thin individuals. The stomach and spleen are mainly found in the left upper quadrant, LUQ, and the left hypochondrium epigastric regions. The spleen in particular lies quite posteriorly, projecting onto the left 9th, 10th, and 11th ribs laterally, making it vulnerable to fracture of these ribs. The cecum and appendix are typically located in the right lower quadrant, RLQ, or the right inguinal region. The base of the appendix often projects onto McBurney's point, classically described as 1/3 of the way along a line from the acies to the umbilicus, a common site of maximal tenderness and acute appendicitis. The end of the descending colon and the sigmoid colon are generally found in the left lower quadrant, LOQ, or the left inguinal region. Pain from sigmoid diverticulitis is often localized here. The kidneys project onto the back in the flank regions, specifically in the paravertebral gutters. The left kidney usually sits slightly higher, roughly T11 L2 L3, than the right kidney, T12 L3, partly due to the liver pushing the right kidney down. Their superior poles are protected by the lower ribs, rib 11 for left, rib 12 for right.
This mental mapping is clearly a core skill.
Absolutely. It's fundamental for accurate physical examination and for interpreting imaging studies effectively.
Okay, this is where all this incredibly detailed anatomical knowledge truly pays off. Understanding real-world clinical scenarios. Let's talk about how this deep knowledge translates into the diagnosis and treatment of conditions that affect the abdomen. Where should we start?
Absolutely. Clinical relevance is where anatomy truly comes to life and transforms into actionable understanding for the elite professional. Let's start with how we even get into the abdomen surgically. Let's discuss surgical access and techniques. Accessing the abdomen for diagnosis or treatment often involves incisions in the anterior abdominal wall. Traditionally, a laparotomy, which is often a large central craniocaudad head-to-tail incision, typically along the linea alba, provides wide access for exploratory procedures and optimal visualization of the entire peritoneal cavity. Great for emergencies or complex cancer surgery.
The big open operation.
Exactly. However, in recent decades, laparoscopic surgery, also known as minimally invasive or keyhole surgery, has absolutely revolutionized many abdominal procedures. This technique uses several small incisions, often just 1 to 2 centimeters long. Through these ports, specialized long, thin instruments, a laparoscope, which is basically a camera on a stick to transmit magnified images to a monitor, and a gas, typically carbon dioxide, are introduced.
Why a gas?
The CO2 is used to insufflate or inflate the abdominal cavity, creating a working space called a pneumoperitoneum. This lifts the abdominal wall away from the organs, allowing surgeons to see and operate safely. The benefits are significant. Less postoperative pain, much shorter hospital stays, faster recovery times, fewer wound complications like infections or hernias, and improved cosmetic outcomes.
Sounds much better for the patient if possible.
Generally, yes, for many elective procedures like gallbladder removal or appendectomy. The latest advance in this area is laparoendoscopic single-site surgery, LESS, which uses a single incision, usually hidden within the umbilicus, to introduce a special port with multiple operating channels. This aims to further reduce invasiveness and improve cosmesis, although it can be technically more challenging for the surgeon. Each technique, open, laparoscopic, LESS, has its advantages, disadvantages, and specific indications, guided by the pathology, patient factors, and surgeon's expertise.
Okay, let's move on to something really common. Hernias. Weaknesses exploited.
Yeah.
You mentioned the groin's inherent developmental weakness makes hernias a profoundly common clinical issue.
Yes, they represent one of the most frequent surgical pathologies worldwide. Inguinal hernias are by far the most prevalent type, occurring much more commonly in men than women, probably about 25 times more often, due to the passage of the spermatic cord, creating a larger potential defect. They are precisely classified into two main types based on their relationship to the inguinal canal structures and the inferior epigastric vessels. First, an indirect inguinal hernia. This is the most common variety overall, often considered congenital because it results from the failure of the processus vaginalis to completely obliterate. The peritoneal sac enters the inguinal canal through the deep inguinal ring, which lies lateral to the inferior epigastric vessels, and then traverses part or all of the canal, potentially exiting the superficial ring. If large enough, it can extend down into the scrotum or labia majora. Think of it as following the path the testes took.
Following the original path.
Exactly. Second, a direct inguinal hernia. This is usually acquired, more common in older men, with weakened abdominal musculature, particularly the posterior wall of the inguinal canal, the transversalis fascia. Here, the peritoneal sac pushes directly forward through that weakened posterior wall, specifically within a region known as the inguinal triangle, or Hesselbach's triangle. Crucially, it emerges medial to the inferior epigastric vessels. It does not pass through the deep inguinal ring or traverse the full length of the canal, typically.
Medial versus lateral to the vessels is key then?
Absolutely key for classification.
Hmm.
Clinically, both types of inguinal hernia characteristically appear as a bulge above the inguinal ligament and often medial to the pubic tubercle.
Okay, what about femoral hernias?
In contrast, femoral hernias are distinct and less common, but more dangerous. They occur when abdominal contents protrude through the femoral ring and into the femoral canal, which lies below the inguinal ligament and lateral to the pubic tubercle, descending into the upper thigh. These are often acquired significantly more common in women, especially those who have had multiple pregnancies, than men, possibly due to their wider pelvis altering the femoral canal anatomy.
Why are they more dangerous?
They are particularly dangerous because the femoral ring is narrow and has rigid boundaries. Inguinal ligament anteriorly, lacunar ligament medially, pectineal ligament posteriorly, femoral vein laterally. This makes femoral hernias highly prone to becoming irreducible, stuck, and then strangulated, meaning the blood supply to the herniated contents, often bowel, gets cut off. Strangulation is a surgical emergency requiring immediate intervention to prevent tissue death and perforation.
Okay, any other common types?
Yes. Other types include umbilical hernias, either congenital where the umbilical ring doesn't close fully after birth, or acquired around the navel in adults, often exacerbated by conditions causing increased intra-abdominal pressure like obesity, ascites, or pregnancy. Incisional hernias, occurring through a defect in a previous surgical scar, often due to poor wound healing, infection, or excessive tension on the closure. And relatively rare Spigelian hernias, protruding through the linea semilunaris, often near the level of the arcuate line, lateral to the rectus sheath. The absolute key risk for all types of hernias is strangulation. When the contents herniate through a tight defect, the neck of the hernia sac can compress the blood vessels supplying the contents. This leads to ischemia, lack of blood flow, infarction, tissue death, and potential perforation, spilling bowel contents into the surrounding tissues or peritoneal cavity, leading to sepsis. This is why elective repair of many hernias is recommended. Careful physical examination, feeling for a cough impulse, a bulge that appears or increases with coughing, which raises intra-abdominal pressure, and identifying the precise anatomical location relative to landmarks like the pubic tubercle and inguinal ligament are critical for accurate diagnosis and planning appropriate surgical management.
Makes sense. Let's turn our attention now to gastrointestinal pathology and diagnostics. Lots can go wrong here. What about ulcers?
Right, duodenal ulceration specifically. Ulcers most commonly occur in the first part of the duodenum, the duodenal cap or bulb, just beyond the stomach's pylorus. The anatomical location of the ulcer dramatically impacts its clinical danger profile.
Location matters. How so?
Posterior duodenal ulcers are particularly perilous. Why? Because the posterior wall of the first part of the duodenum lies directly over major arteries. These ulcers can erode deeply and penetrate right into the gastroduodenal artery, or, perhaps even more commonly, its branch, the posterior superior pancreaticoduodenal artery. Erosion into these vessels can cause torrential, potentially fatal upper gastrointestinal hemorrhage. This requires immediate endoscopic or surgical intervention to control the bleeding. Anterior duodenal ulcers, on the other hand, face the open peritoneal cavity. If they erode through the full thickness of the duodenal wall, they cause perforation, spilling acidic gastric and duodenal contents directly into the peritoneal cavity. This leads to acute chemical, then bacterial peritonitis, a diffuse inflammation of the peritoneum, which is a surgical emergency. Clinically, this often presents with sudden, severe abdominal pain, rigidity of the abdominal wall, and is often detected radiologically by the presence of free air under the diaphragm, subdiaphragmatic gas, on an upright chest or abdominal X-ray.
Posterior bleeds, anterior perforates. Got it. What about appendicitis?
Acute appendicitis, the inflammation of the vermiform appendix, that little worm-like appendage off the cecum, is one of the most common surgical emergencies. It usually involves obstruction of its narrow lumen, often by a fecalith, a small, hard mass of stool, thickened mucus, or sometimes enlarged lymphoid tissue following a viral illness. This obstruction leads to mucus buildup, increased pressure, impaired blood flow, bacterial overgrowth, inflammation, and potentially gangrene and rupture.
And the pain migration.
Yes, the classic pain pattern often migrates. It frequently begins as a vague, poorly localized colicky pain in the central periumbilical region. This is visceral referred pain from the appendix, a midgut structure T10 innervation. Then, typically after 6-12 hours, as the inflammation progresses and irritates the adjacent parietal peritoneum lining the abdominal wall in the right iliac fossa, the pain shifts and becomes much more localized, sharp, constant, and intense in the right lower quadrant, typically maximal around McBurney's point. This precise anatomical understanding of pain migration and localization guides diagnosis and surgical planning, usually leading to appendectomy.
Okay, bowel obstruction. Sounds serious.
It can be very serious. This can be either mechanical, meaning there's a physical blockage, or functional, meaning peristalsis stops working properly. Mechanical obstruction can be caused by something inside the lumen, like a gallstone that eroded into the bowel, something in the bowel wall, like a tumor or stricture from Crohn's disease, or something outside compressing the bowel, like adhesions from previous surgery, which are very common, or a strangulated hernia. Functional obstruction is called an ileus, where peristalsis ceases, often seen temporarily after abdominal surgery, or due to electrolyte imbalances, certain medications, or severe infection inflammation like pancreatitis.
How do the symptoms differ?
Symptoms vary depending on the level and completeness of the obstruction. High obstruction, for example, proximal small bowel, may not cause significant abdominal distension initially, but will cause early profuse vomiting, often bilious. Low obstruction, for example, distal large bowel, typically leads to more gradual onset. Marked abdominal distension and vomiting may occur later and be feculent, smelling like feces. Cardinal features usually include colicky abdominal pain, vomiting, abdominal distension, and absolute constipation, failure to pass flatus or stool.
And the danger.
Untreated, complete bowel obstruction can rapidly lead to severe dehydration and electrolyte imbalance from vomiting and fluid sequestration in the bowel. Increased pressure within the obstructed loop can compromise blood flow, leading to bowel ischemia, infarction, death, and perforation, resulting in peritonitis and sepsis. This is a life-threatening progression requiring urgent diagnosis, often with CT scan, and intervention, which might involve fluid resuscitation, nasogastric decompression, and often surgery to relieve the obstruction.
What about diverticular disease?
This involves the development of multiple small outpouchings, or diverticula, singular diverticulum, which are like little pockets bulging outward through the muscular wall of the colon. They occur most commonly in the sigmoid colon, probably because the intraluminal pressure is highest there, while the mere presence of diverticulosis is often asymptomatic and very common in older adults.
Right, many people have it.
Yes. But when a diverticulum becomes obstructed, typically by a fecalith and subsequently infected and inflamed, it leads to diverticulitis. This causes localized abdominal pain, classically in the left lower quadrant over the sigmoid colon, accompanied by fever and changes in bowel habits.
And complications.
Complications can be severe. These include abscess formation adjacent to the inflamed colon, perforation leading to peritonitis, fistula formation, an abnormal connection between the colon and adjacent organs like the bladder, causing recurrent urinary tract infections and pneumaturia gas in urine, or vagina, or stricture formation causing bowel obstruction. Management ranges from antibiotics for uncomplicated cases to surgery for complications.
How do we diagnose all these gut issues?
We have a range of diagnostic techniques. Historically, barium studies, like a barium swallow for the upper GI tract or a barium enema for the colon, were common. The patient drinks or is given an enema containing barium sulfate, which coats the lining of the gut and allows visualization of the lumen, mucosal patterns, filling defects, like tumors,
Hmm.
or strictures using X-ray fluoroscopy. They're used less now, but still have roles. Endoscopy is hugely important. This involves using flexible fiber optic or video endoscopes to directly visualize the inner lining of the GI tract. Esophagogastroduodenoscopy, EGD, looks at the esophagus, stomach, and duodenum. Colonoscopy examines the entire colon. These allow for direct visualization, taking biopsies of suspicious areas and performing minor therapeutic procedures like removing polyps, which can prevent colon cancer, or stopping bleeding. Capsule endoscopy, swallowing a tiny camera, can visualize the small intestine.
Direct visualization seems key.
It is. And then there's cross-sectional imaging. Computed tomography, CT scans, provide detailed images of the abdominal organs, bowel wall, mesentery, vessels, and lymph nodes. It's invaluable for diagnosing appendicitis, diverticulitis, bowel obstruction, tumors, trauma, and assessing the extent of disease. Magnetic resonance imaging, MRI, is also used, particularly good for soft tissue contrast, assessing liver and biliary pathology, rectal cancer staging, and evaluating inflammatory bowel disease, IBD activity without radiation. MRI is particularly useful for dynamic assessment in IBD, showing bowel wall thickening, inflammation, strictures, fistulas, and increased vascularity of the mesentery. CT colonography, or virtual colonoscopy, uses CT data to create 3D reconstructions of the colon, offering a less invasive screening alternative to traditional colonoscopy for some patients.
Oh, okay, let's move to the accessory organs and spleen. What about liver, pancreas, and spleen? Disorders and interventions. Gallstones seem common.
Gallstones are extremely common, formed from cholesterol or bilirubin, and often asymptomatic, discovered incidentally. However, they can cause significant problems. If a stone temporarily obstructs the cystic duct, draining the gallbladder, it causes severe colicky pain known as biliary colic. If the obstruction persists, it leads to inflammation of the gallbladder, cholecystitis, causing constant right upper quadrant pain, fever, and localized tenderness.
And a referred shoulder pain.
Yes, inflammation near the diaphragm can irritate the phrenic nerve, causing referred pain to the right shoulder tip, C3-C5 dermatomes. If stones migrate out of the gallbladder and into the common bile duct, cholelithiasis, they can cause obstruction, leading to jaundice, yellowing of skynies due to bilirubin backup, pancreatitis, if the pancreatic duct is also blocked, and cholangitis, infection of the bile ducts, a serious condition.
How are these diagnosed and treated?
Ultrasound is usually the first test for gallstones. For stones in the bile duct, MRCP, magnetic resonance cholangiopancreatography, a non-invasive MRI technique, provides excellent visualization of the bile and pancreatic ducts. ERCP, endoscopic retrograde cholangiopancreatography, is an invasive endoscopic procedure where a scope is passed into the duodenum, a catheter is inserted into the bile duct opening, ampulla of Vater, and dye is injected for X-ray imaging. Crucially, ERCP allows for therapeutic interventions like stone removal from the bile duct using baskets or balloons, or placing stents to bypass obstructions. Cholecystectomy, gallbladder removal, usually done laparoscopically, is the definitive treatment for symptomatic gallstones.
What about liver cirrhosis? We mentioned portal hypertension earlier.
Yes, cirrhosis is the end-stage result of chronic liver damage from various causes like chronic viral hepatitis, B or C, alcohol abuse, or fatty liver disease. It involves progressive, irreversible liver damage characterized by widespread fibrosis, scarring, and the formation of abnormal regenerative nodules leading to severely distorted liver architecture. This structural damage inevitably obstructs blood flow through the liver, causing portal hypertension.
And the consequences cascade.
They do. Portal hypertension leads to the development of those portosystemic collateral vessels, varices, cup-up medusae, ascites, accumulation of protein pore fluid in the peritoneal cavity due to increased pressure and low albumin synthesis by the failing liver, splenomegaly, enlarged spleen due to blood backing up, impaired synthesis of clotting factors, increasing bleeding risk, and potentially hepatic encephalopathy, neurological dysfunction caused by the buildup of toxins like ammonia that the failing liver can no longer detoxify. Diagnosis often involves blood tests, imaging, and sometimes a liver biopsy. If ascites or severe coagulopathy is present, the biopsy might be performed via a transjugular approach through the internal jugular vein, hepatic vein, into the liver to minimize the risk of abdominal bleeding associated with a percutaneous through-the-skin approach.
Pancreatic cancer. You mentioned it's often called the silent killer.
Tragically, yes, often due to its typically late diagnosis and aggressive biological behavior. Most pancreatic cancers are adenocarcinomas arising from the ductal cells. Tumors located in the head of the pancreas, the most common site, can compress the common bile duct as it passes through, leading to progressive, often painless, obstructive jaundice, a major red flag symptom. They can also invade the duodenum, causing gastric outlet obstruction and vomiting. Tumors in the body or tail often present even later, perhaps with vague abdominal or back pain, weight loss, or new onset diabetes.
And surgery is difficult.
Surgical resection, typically a pancreatic duodenectomy or Whipple procedure for head of pancreas tumors, is the only potential cure, but it's an extremely complex and major operation. This is due to the pancreas's deep retroperitoneal location and its intimate proximity to vital vascular structures like the portal vein, superior mesenteric artery and vein, and the IVC, which are often invaded by the tumor by the time of diagnosis. Unfortunately, most patients present with locally advanced or metastatic disease that is unresectable, limiting treatment options primarily to chemotherapy or palliative care.
What about splenic disorders?
The spleen, located in the left upper quadrant under ribs 9-11, has a thin capsule and is highly vascular, making splenic rupture a relatively common and potentially dangerous consequence of blunt abdominal trauma, especially involving the left lower chest or upper abdomen, like a steering wheel injury or fall. Rupture can lead to profuse and life-threatening intraperitoneal bleeding, hemoperitoneum, requiring urgent diagnosis, often with CT or focused ultrasound fast scan, and intervention. While treatments increasingly aim for splenic preservation, splenectomy or partial splenectomy, or even non-operative management in stable patients, emergency splenectomy, surgical removal of the spleen, may be necessary to control hemorrhage.
And splenomegaly?
Splenomegaly, or splenic enlargement, can result from a wide variety of conditions. These include infections like mononucleosis, malaria, hematological disorders like leukemia, lymphoma, hemolytic anemias, storage diseases, or congestion due to increased venous pressure, most notably in portal hypertension. An enlarged spleen is itself more fragile and prone to rupture, even from minor trauma. Palpating an enlarged spleen below the left costal margin is an important clinical finding.
Okay, let's shift focus to the urinary tract. Stones, cancer, and transplants. Kidney stones sound painful.
Ureteric stones, calculi, cause arguably some of the most severe pain known, often described as worse than childbirth. The pain, termed renal colic, is typically excruciatingly severe, sudden in onset and colicky, coming in waves. It usually originates in the flank, loin region between the ribs and hip on the back, and classically radiates downwards and anteriorly towards the groin, and may extend into the scrotum in men or the labia majora in women.
Why that radiation pattern?
This characteristic radiation pattern is due to the passage of the stone causing ureteral distension and spasm, triggering visceral afferent nerves that travel back to the T11L2 spinal cord levels. Since somatic nerves from the skin of the flank, groin, and external genitalia also enter at these same levels, the brain interprets the pain as coming from these somatic areas, another example of referred pain. Hematuria, blood in urine, often microscopic, is also very common. Diagnosis is typically made rapidly and accurately using a non-contrast, low-dose CT scan of the kidneys, ureters, and bladder, CT-CoUB, which can identify the size, location, and density of stones, or sometimes ultrasound, especially in pregnant patients, to avoid radiation.
What about urinary tract cancer?
Two main types are important here. Renal cell carcinomas, RCCs, are the most common type of kidney cancer in adults, arising from the tubular epithelium of the kidney. They are somewhat unique among cancers for their propensity for venous invasion. The tumor can grow directly into the small renal veins, then into the main renal vein, and can even extend as a continuous tumor thrombus up the inferior vena cava, sometimes reaching as far as the right atrium of the heart. This has major implications for surgical planning. The other important type is transitional cell carcinomas, TCCs, now often called urothelial carcinomas. These arise from the urothelium, the specialized epithelial lining that covers the entire urinary tract from the renal calyces and pelvis, down the ureters into the bladder, and extending into the proximal urethra. Because this lining is continuous, the urothelium is considered a single unit. This means that a diagnosis of TCC in one location, like the bladder, which is most common, necessitates a thorough investigation and ongoing surveillance of the entire urinary tract, upper tracts and bladder, for other potential synchronous present at the same time or metachronous developing later tumors, as the entire lining is considered at risk.
That's a crucial concept. What's a nephrostomy?
A nephrostomy is an important interventional, radiological, or urological procedure. It involves placing a drainage tube percutaneously, through the skin of the flank, directly through the kidney tissue, renal cortex, so that the tip lies within the renal pelvis, the funnel-shaped structure that collects urine from the kidney before it enters the ureter. Its primary function is to drain obstructed urine externally, bypassing a blockage further down in the ureter, for example, from a stone, tumor, or stricture. This is vital for relieving pressure, preserving kidney function, and managing infection, pyonephrosis, associated with the obstruction.
And kidney transplant. Where do they put the new kidney?
Transplanted kidneys are generally not placed in the original kidney's location in the retroperitoneum high up on the posterior abdominal wall. Instead, they are typically placed in the iliac fossa, usually the right one, in an extraperitoneal position.
Extraperitoneal. So outside the main abdominal cavity lining?
Exactly. The surgeon makes an incision in the lower quadrant, pushes the peritoneum medially without opening it, and places the donor kidney in the space created in the iliac fossa, nestled against the iliacus muscle. This location is chosen for several excellent reasons. It allows for relatively easy and safe vascular anastomosis connection of the donor renal artery and vein to the recipient's external or internal iliac vessels, which are large and accessible here. The donor ureter can be implanted directly into the recipient's nearby bladder. Being extraperitoneal and superficial makes the transplanted kidney easily accessible for straightforward post-operative monitoring via palpation, ultrasound for blood flow assessment, and percutaneous biopsy if rejection is suspected. It also generally avoids the potential complications associated with a major intra-abdominal operation.
Makes sense. Okay, let's cover vascular interventions next. Abdominal aortic aneurysm sounds serious.
Abdominal aortic aneurysm, OPAL, is a pathological, localized dilation or bulging of the abdominal aorta, typically occurring in the segment below the origin of the renal arteries, infrarenal. It's usually caused by weakening of the aortic wall due to atherosclerosis and other factors. The main danger is rupture. Large aneurysms, generally defined as having a diameter of 5.5 centimeters or greater, carry a significant and exponentially increasing risk of rupture, which is a catastrophic, life-threatening emergency with very high mortality, often causing massive internal bleeding into the retroperitoneum or peritoneal cavity.
How are they treated?
Treatment aims to prevent rupture. Historically, this involved major open surgical repair, where the aneurysmal segment of the aorta is clamped, open, and replaced with a synthetic tube graft. More commonly now, especially for suitable anatomy, treatment is via endovascular aneurysm repair.
Endovascular, inside the vessel.
Exactly. EVAR is a minimally invasive technique where a compressed stent graft, a fabric tube supported by a metal scaffold, is inserted via catheters introduced through the femoral arteries in the groin. Under X-ray guidance, the stent graft is positioned across the aneurysm and deployed, effectively lining the aorta from within and excluding the aneurysm sac from blood flow and pressure. It generally involves less physiological stress and faster recovery than open surgery.
Any complications with EVAR?
A critical potential complication specific to EVAR is an endoleak. This occurs when blood continues to flow into and pressurize the aneurysm sac outside the stent graft. There are different types, but it can happen due to an incomplete seal at the top or bottom of the graft, leakage through the graft fabric, or commonly retrograde flow into the sac from collateral vessels like patent lumbar arteries or an inferior mesenteric artery that arise from the aneurysm sac itself. Endoleaks defeat the purpose of the repair, maintain the risk of rupture, and often require further intervention to seal them off.
Okay, what about deep vein thrombosis, DVT interventions?
Deep vein thrombosis refers to the formation of blood clots, thrombi, in the deep veins, most commonly in the legs or pelvis. The primary and most feared complication is pulmonary embolism, PE, where a piece of the clot, an embolus, breaks off, travels through the venous system to the right side of the heart, and then lodges in the pulmonary arteries supplying the lungs. A large PE can cause sudden death or severe cardiorespiratory compromise. Standard treatment for DVT is anticoagulation, blood thinners, to prevent further clot formation and allow the body to dissolve the existing clot.
But what if anticoagulation isn't possible?
Exactly. In specific situations where anticoagulation is contraindicated, for example, due to active bleeding or very high bleeding risk, or has failed to prevent recurrent PE, an inferior vena cava (IVC) filter can be inserted. This is a small, umbrella-like or cage-like metallic device, usually placed via catheters inserted through the femoral or internal jugular veins into the IVC below the level of the renal veins. Its purpose is to physically trap significant emboli migrating from the lower limbs or pelvis, preventing them from reaching the pulmonary arteries and causing a PE, while still allowing normal blood flow back to the heart.
A safety net, basically.
A mechanical safety net, yes.
Finally, let's touch on lymphoma and retroperitoneal dissection and surgical management of GI conditions.
Right. Hodgkin's lymphoma and non-Hodgkin's lymphoma are cancers of the lymphatic system that often present with enlarged lymph nodes, which can occur anywhere, including the retroperitoneal space alongside the aorta and IVC. For certain conditions requiring removal of these nodes, particularly metastatic spread from testicular cancer, a surgical procedure called retroperitoneal lymph node dissection, RPLND, may be performed. This is a major operation that requires a specific surgical approach, often involving retracting the parietal peritoneum medially to expose the retroperitoneal space without fully entering the peritoneal cavity. This allows access to the lymph nodes clustered around the great vessels, aorta and IVC, where the primary lymphatic drainage from the testes occurs.
Keeping it extraperitoneal.
Often preferred, yes, especially in the post-chemotherapy setting, as it can minimize bowel complications like adhesions. Lastly, surgical management of GI conditions often involves creating ostomies. These are crucial surgical procedures where an artificial opening, called a stoma, is created on the anterior abdominal wall to externalize a segment of bowel, thereby diverting its contents away from the distal bowel or rectum. An ileostomy brings the ileum, small bowel, to the surface, typically after removal of the entire colon, total colectomy. A colostomy brings a part of the colon, large bowel, to the surface. These might be temporary to protect a downstream surgical connection, anastomosis, while it heals, or permanent if the rectum has been removed.
What about feeding tubes?
Yes, gastrostomy stomach and jejunostomy involve placing feeding tubes through the abdominal wall directly into the respective organ, primarily for long-term nutritional support when oral intake is impossible or unsafe, for example, after stroke or head neck cancer. A specialized type of urinary diversion is an ileal conduit, often performed after radical cystectomy, bladder removal for cancer. Here, a short segment of ileum is isolated, the ureters are implanted into one end, and the other end is brought to the abdominal wall as a stoma, allowing urine to drain continuously into an external appliance.
And finally, obesity surgery.
Also known as bariatric surgery, these procedures have become increasingly important and effective interventions for patients with morbid obesity, typically BMI 40 or 35 with significant comorbidities, who haven't achieved sustained weight loss through lifestyle changes alone. These surgeries work through different mechanisms. Restrictive procedures, like sleeve gastrectomy, surgically remove a large portion of the stomach, creating a narrow tube or sleeve. This significantly reduces the volume the stomach can hold, leading to early satiety. Malabsorptive procedures, less common now, bypass significant portions of the small intestine, reducing nutrient absorption. Combination procedures, like the very common Roux-en-Y gastric bypass, involve creating a very small stomach pouch, restrictive, and then rewriting the small intestine to connect directly to this pouch, bypassing the rest of the stomach and the duodenum malabsorptive component. These surgeries aim to induce dramatic and sustained weight loss, which in turn can significantly improve or even resolve obesity-related health problems like type 2 diabetes, hypertension, sleep apnea, and high cholesterol. However, they are major operations with potential risks and require lifelong nutritional monitoring and supplementation.
Wow, what an absolutely incredible and deeply comprehensive journey through the human abdomen. We've covered everything from its fundamental structure and its fascinating developmental origins to the intricate dance of its vessels and nerves, and crucially, how all these anatomical pieces fit together, especially when things go wrong in the clinical arena. You, our listeners, now possess a truly professional, deeply informed understanding of this vital central region of the body.
Indeed. We've peeled back the layers to see how a seemingly superficial belly hides a world of astonishing complexity and purpose. We've explored how developmental processes, while essential for shaping us, can paradoxically lead to inherent vulnerabilities like hernias in the groin. And we've seen how the profound interconnectedness of its systems means that a problem in one area, such as the increased pressure of portal hypertension from liver disease, can have wide-ranging, life-altering effects throughout the entire body, from those dangerous esophageal varices to the sometimes striking diagnostic sign of caput medusae on the abdominal wall.
It's a powerful reminder of the body's remarkable design, its incredible capacity for adaptation, but also its delicate balance. From the vigilant policeman of the abdomen, the greater omentum rushing to wall off infection, to the tragic reality of the silent killer that pancreatic cancer often is, the abdomen truly is an endless, rich source of knowledge that demands, well, a deep, deep dive like this one.
This deep dive in particular raises an important question for us to perhaps ponder as we close. Considering the immense complexity we've discussed, the numerous protective mechanisms built in, and the body's extraordinary capacity for compensation, what do you think is the most surprising or perhaps the most ingenious way the body adapts or finds a workaround when a major abdominal system like that hepatic portal system we explored is significantly compromised? Especially thinking about the development of those portosystemic anastomoses and their varied, sometimes bizarre clinical manifestations. It's really a testament to life's tenacity, isn't it?
A truly fantastic and profound thought to leave us with, highlighting the ultimate resilience and ingenuity woven into our very being. Thank you so much for guiding us through that. And thank you for joining us on this deep dive. We hope you feel not just informed, but genuinely enlightened and empowered by this incredible world within us.